First of all, if everybody can't hear me, I've been accused of mumbling from time to time, so if you do, just throw something at me, preferably food, because I haven't eaten either. But we're going to talk about gastroesophageal reflux disease. Has a whole bunch of different names: GERD, reflux esophagitis, acid reflux, kind of all interchangeable. We'll kind of talk about what causes it, what we can do with it, and what kind of hopefully are going to be options for us in the future. So it's defined as chronic symptoms or mucosal damage caused by acid coming up into the esophagus and abnormal reflux. It's normal to have a little bit of acid come up in there. It's normal to have the lower esophageal sphincter, or I'll go through the anatomy in just a moment, relax a little bit so that you can belch. But if it relaxes too much too often, it allows the acid to come up in there and causes damage. And so one of the things for us that we look for, one of those hallmark things, is acid reflux. And if you're having 2 heartburn episodes per week, I need to know about it, your family doctor needs to know about it, somebody needs to know about it, because that's kind of that threshold that we want to look for to say you may be having more than just a little bit of heartburn, but you may be having damage. The other thing we look for is it adversely affects your well-being. It's really been fascinating as we've done studies on people's well-being, and people that have acid reflux have worse well-being than people with angina, people with heart failure, people with all sorts of heart issues, all sorts of other issues. So it is one of those that does affect your lifestyle quite a bit. So the thing that really causes this is the esophagus going down into the stomach here. This is the diaphragm, the muscle that separates the chest from the abdomen. And right here is the lower esophageal sphincter. That's a little valve that's supposed to squeeze down tight, keep acid from coming backwards on you. It becomes weak and relaxes, and so it allows the acid content to go up into the esophagus. You may have some decreased clearance of the esophagus, so the contact time is longer for that. This also shows a hiatal hernia where the stomach has come up above the diaphragm. Normally, the lower esophageal sphincter is right at the diaphragm and helps add some extra pressure to the lower esophageal sphincter to help keep it closed. If you have a hiatal hernia, you lose that tone there. Sometimes they're called sliding hiatal hernias because they'll go up and down, up and down, up and down, but it's still the same process. Typically, we just treat the acid reflux as our primary problem. We can also see people that have delayed gastric emptying, keeps the stomach full all the time. If they have an obstruction of the bottom part of the stomach, again, that will keep the stomach full and allows it to reflux or regurgitate up into the esophagus. So classically, we look for heartburn, indigestion, regurgitation, a sense of burning coming up into the chest. You actually may feel a sense of food or liquid coming into the back of your throat. That's a fairly classic description of heartburn and indigestion. Only about 60% of people have both heartburn and regurgitation. So we really don't capture everybody just based on those symptoms. We see a variety of other symptoms. Non-cardiac chest pain. We see a lot of people come in the hospital having chest pain, think it's their heart. They go get their heart checked out. It's doing fantastic. Gastroesophageal reflux is the next most likely culprit. There are some other things. We can see a variety of extraesophageal symptoms as well, including a variety of oropharyngeal or throat symptoms from cough, laryngitis. People can have worsening of their asthma. They can have symptoms all from that. They can lose their voice. People that sing can't get the range that they could previously. And you can see there's a variety of other potential problems we worry about. So typical diagnosis of gastroesophageal reflux usually initially is made by symptoms of reflux, and then people most likely get treated. I'll go through treatment with different medicines in a moment and dietary and lifestyle changes. Some of the atypical things usually go on, and because we're not really sure if that's what it is, they'll get an endoscopy where we take a little camera and have them swallow it after they are sedated and go down. There are some other ways. We do have a monitor that we can actually put a probe on the esophagus to measure the amount of acidity that's coming up in there to confirm that. And so there's a variety of ways to do that. Most people that have classic reflux will just simply get treated initially and see if that takes care of it. There are some things we really want to know about that will kind of change from regular heartburn or reflux. If you're having trouble with food getting stuck, if you're losing weight, if you're anemic or bleeding, those are kind of hallmark things for us to move forward with more diagnostic procedures with that. So initial treatment is, nobody likes the D word, but as I'm sure Mr. Cabrera is going to show us, you can eat well and still have a healthy diet. But some things with diet and lifestyle, low-fat diet, if you're overweight, lose weight, elevate the head of the bed, especially if you're having nighttime symptoms, but even if you don't know that, and we want you to elevate the whole bed, not just put pillows under the bed. That bends you in the middle, increases your intra-abdominal pressure, and helps push stuff back. Limit caffeine, alcohol, and chocolate. Note the word limit. If you want to have a piece of chocolate, go ahead. If you want to have an occasional alcoholic beverage, go ahead. But just be aware, those are the things that are more likely to give you issues. And if you're going to do some of these things, make sure you don't do all of them and then go straight to bed, because that's the other thing, is try not to lay down. Don't smoke. Small, frequent meals so you're not filling your stomach up with a big meal. For me, most of the people that I see have already done this, and it didn't help. And so that's when we move on to some other things. I'll move on to that. This is talking about your weight, body mass index, and how much you have transient lower esophageal relaxations. That's what causes acid reflux. Lower esophageal sphincter relaxes and allows acid to come up. And you can see the more you have of your body mass index, the more you have of those. If you can lose weight, that's probably one of the most significant things you can do to your lifestyle to improve acid reflux. Now there's some other things we kind of look for to make sure that you don't have, and I won't go into the workup too much, other than we do have a variety of other things we look for that can mimic similar symptoms. Here's what the esophagus looks like with erosive esophagitis. Erosive meaning it's a beginning ulcer. For me as a gastroenterologist, that means the break in the lining has not gone down deep enough to be an ulcer. But you can see right here is a little erosion. This is grade A, grade B. There are longer erosions. C, more inflammation all the way around. And in grade D, it's circumferential, goes all the way around the esophagus. This is the esophagus, hollow tube, as if we're looking down that with our camera. Here's another way of looking at that with really good pictures right before you're supposed to have dinner. Hopefully we're not affecting anybody. But you can see there's actually a break in the lining there. So the esophageal lining has been eroded or eaten away by the acid. And it gets worse and worse. This person actually has a pretty significant stricture, or a ring of scar tissue that's developed. One of the things we can do with an endoscope is go in and put a balloon in there and dilate that, stretch that open so that people can swallow adequately. One of the sneaky things about this is the amount of symptoms that you have doesn't always predict the severity of your disease. And so again, if you're having heartburn a couple times a week, use that as a hallmark and go get it checked out, because you may have really significant erosive esophagitis. You may have non-erosive esophagitis, NERD, but we still treat it the same way, but the risk of complications is much more significant with erosive esophagitis, and the way to differentiate that is some of the testing, most commonly with an endoscopy first. Again, some of the things you can do with your lifestyle, and again, weight loss being significantly improving that, elevating the head of the bed, late evening meals or avoiding late evening meals being some of the most prominent things you can do to improve your lifestyle, to improve gastroesophageal reflux. There are some complications that we can see with this. If you have acid up over a long time, as I said, you can certainly get pain with that, and that pain can impact your life. You can get a change in the lining called Barretts Esophagus that puts you at increased risk of getting cancer of the esophagus, and that's actually one of the leading causes of esophageal cancer and one of the increasing rate of esophageal cancer that's going on. The only way to tell Barrett's esophagus is take an endoscope down and take biopsies of the esophagus, and that's one of the things we almost always do with somebody that's had acid reflux. And there's general recommendation, if you've had acid reflux and you've been treated, you should have at least a one-time endoscopy to prove that you don't have Barrett's esophagus. There are some other ways to look at that. There is a pill that you can swallow that's a little bit easier, that we can go visualize the inside lining. Can't take a biopsy, but we can tell, does it look like you need a biopsy or not. You can develop strictures or a ring of scar tissue, as I said. We can dilate those or stretch those open. They can be recurrent in some people, especially if we don't have the acid controlled. It does put you at increased risk for esophageal cancer, both a couple of different types of cancer. Can get oropharyngeal complications or symptoms or pulmonary complications. One of the things with people with asthma, especially if they're on steroids, if they have uncontrolled acid reflux, their need for steroids is going to be much higher. If we can get their acid reflux controlled better, their need for steroids can be significantly improved. So it does play a role with stuff other than just the lungs. Here's a picture of somebody with Barrett's esophagus, and to kind of compare it, normally this junction here would be a ring, and a fairly smooth ring down here. And what has happened is this whole length of tissue here has changed. And not only has it changed from the normal esophageal lining, it has changed to lining that looks like intestinal tissue up in the esophagus. We take this and there is a procedure that we can do to try and eradicate that abnormal tissue there. One of the things we also want to do is periodically go back and biopsy that to see if it has changes where it's trying to move toward cancer, so we can obviously intervene before it becomes cancer. Here is a slide kind of talking about the risk of cancer, but it also is talking about the absence of heartburn or regurgitation. And so the people that have absolutely no symptoms don't have much of a chance to come to me so that I can go down and look. And so that's why that is such an important threshold. If you're having even what seems like a little bit of heartburn, go get it checked out. Because if we can identify people that have Barrett's esophagus, we can monitor it and we can keep you from getting cancer. So this is showing a pH probe, one of the other ways for us to tell how much acid is coming up into the esophagus. So this is a little probe about the size of an end of a pencil that we put into the bottom of the esophagus. We suck it onto the inside lining and it stays there for 4 or 5 days and then falls off. But it has a radio transmitter in it to transmit to this beeper looking thing that you carry around, and it tells us how much acid is coming up in there. We can use this for people that we're having difficulty trying to assess. Are they having acid reflux? Are they having other symptoms? Sometimes we will use that to assess how are we doing with our therapy. You know, are they having symptoms? Are we controlling their acid? Is their symptoms still coming from acid reflux? We used to have to put a tube down the nose and leave it in the esophagus for 24 or 48 hours. As you can imagine, nobody tolerated that very well. I had one of the nurses here have that done, and she made it all the way to her car before she took it out. So this is much better tolerated than the people that we need to do that. So we do think of acid reflux or GERD as a chronic problem. Unfortunately, like I said, the lower esophageal sphincter is weak. We don't have a good medicine to tighten that up. I don't have a good exercise to tell you to do to tighten that up. And so when we do therapy, especially when we see people with erosive esophagitis, we do want to continue that ongoing. Now, we will sometimes see people that we have to put on a higher dose to get them initially calmed down, and we can try and reduce that. And as I'll talk some of the potential problems with the medicines, we do try and reduce the medicines to keep people controlled or calmed down. But it typically is a chronic disorder unless you go strengthen the lower esophageal sphincter. And I'll talk a little bit about some of the maneuvers or ways to do that. So our standard therapy is to put people on some kind of medicine. Esomeprazole is the generic for Nexium. There are several different medicines that are similar to that. They all have similar type side effects: headache, diarrhea, abdominal pain. It always puzzles me how you have a medicine, you're treating somebody with stomach problems, and then it gives you stomach pain, but it is one of the potential problems with that. These are all short-term problems that should occur almost immediately when you get put on the medicine. If you're going to have it, you should have it very, very early on. If you're not going to have it, then probably not. There are some long-term problems, as I just said. We do think of this as a chronic disorder, a chronic problem, so we'll keep people on this long-term. One of the things we can see is it does increase your risk of an infection of the intestine called Clostridia difficile. Has been a real issue in hospitals all across the country trying to get that controlled. In especially nursing home patients, it seems to be a problem for aspiration. Nursing home patients, unfortunately, a lot of them are bedridden, don't have the protective mechanisms of people that are ambulatory in terms of that. And so because you don't have the normal acidity of the stomach, it doesn't kill all the normal bacteria in your stomach. And so if they regurgitate some, aspirate it down into their lungs, it puts them at an increased risk for pneumonia. It can cause, put you at risk for demineralization of your bones. And so again, one of the things we want to do is try and reduce the medicine to whatever lowest dose that keeps you controlled. It can increase your risk of certain types of polyps of the stomach. Fundus is a top part of the stomach. They are not precancerous type of polyps, but they can cause some issues otherwise. And so when we go in with scopes, we typically will take most of those out. Yes, ma'am.
What does PPI mean?
Oh, I'm sorry. PPI is a proton pump inhibitor. That is the category of medicine. Proton pumps are the acid pumps of the stomach. That's what produces that. And so you're blocking the amount of acidity of the stomach with a proton pump inhibitor. You're inhibiting that. The way those medicines work, esomeprazole or Nexium is kind of one of those we use. Prilosec, Acifex, there's a number of different medicines. They block the pumps that produce acid. We typically tell people to take that about 30 minutes to 60 minutes before a meal. The way they work is you take it in, it gets absorbed, goes circulating into the bloodstream, goes back to your stomach, waiting for the pumps to be activated. The thing that activates them is food. So you eat something, the pumps become active, the medicine jumps on it and shuts it down. So, sorry. So, classic therapy for gastroesophageal reflux is medical therapy. You have some potential problems. If you don't want to do medical therapy, what are our choices? As I said, I've been practicing for a while, and I've seen a number of procedures come and go. When I was actually in training, there was a procedure called an angel chick procedure, where they would take a little donut and wrap it around the lower esophageal sphincter and tighten it down and help support that. Well, there were some problems with that, complications from that, so everybody quit doing that. The classic is a laparoscopic fundoplication. I have a picture that kind of shows what that is, but a surgeon has to go in and they take the top part of the stomach, wrap it around the esophagus, and tie it down. So you physically have to go do something to the lower esophageal sphincter to support it. And that's been the hallmark. Now, they have gotten much better with that particular technique. When I first started practicing, surgeons would have to open people's chests to do that. We didn't do that much back then. Then they got to it where they could do it with an incision in the abdomen. Well, we did it a little bit more often. Now they can do it with a laparoscopic technique where they can go in through a small incision at your belly button and a couple of little incisions, similar to the way most people have their gallbladder taken out. And so it's an easier surgery in terms of how they have to get to what they do. They're still doing the same thing on the inside. They're still doing a fair amount of surgery, and it is still abdominal surgery. It's the only thing that's really stood the test of time in terms of being effective. Strata Procedure is an easier procedure to do. Go in while you're sedated, go in with a device to the bottom part of the esophagus, and again have a diagram of that, and put little needles into the bottom of the esophagus and run a radiofrequency current that disrupts some of the nerves to, one, tighten up the bottom part of the esophagus, but also disrupt some of the transient relaxations to decrease that. Strata Procedure works pretty well for people that have mild to moderate disease. For people that have really more severe disease, it's just not strong enough to do that. Unfortunately, most of the people that really want to have something done are the people that have more severe disease. And Terex is a procedure where would go in with an endoscope and inject a polymer in the bottom of the esophagus, again to try and tighten that up. Didn't really seem to work very well, didn't have long-lasting effect. The polymer sometimes would get extruded and they'd have to have repeat exams. So that one's kind of fallen off the radar at this point. Lower esophageal sphincter wrap, there's a new procedure called Linx where they go in and wrap the lower esophagus with a series of magnets so that the magnets click closed. When you swallow something, they open up, click back closed after it goes by. I don't know if you can hear that. I don't know if you walk by the refrigerator and you get stuck to the refrigerator. Kind of raises all sorts of questions about that. But that's a pretty new procedure. It's just been approved. And as with all of these, kind of what has happened is that it gets approved by the FDA, then it goes through a series of things, then it has to get approved by insurance companies to see if they're going to pay for it. And then after it gets more widely used, we can really see what is the utility. So I'm going to be interested to see how that goes along. There have been several attempts at endoscopic fundoplication, meaning as opposed to going through a laparoscope, go in with an endoscope so there's no incisions. And there's been several different tries at that. None of them have really been fantastic, and I don't think the esophagus is still being used. I think the other two are not really being used too much. And I think of these, I'll be really interested to see what happens with the magnets. The other thing that I'd say with all of this is there's a gazillion people out there with this disorder. Part of the reason we see people that are having problems with the medicines is because there's a gazillion people on those medicines. And so there's a lot of interest in this. There's a lot of people that can be helped with this. There's just a lot of interest. And so if these don't work, somebody's going to come up with another try, and we'll see how that one goes. So this is kind of comparing laparoscopic reflux surgery versus esomeprazole or Nexium, and pretty similar type of results. And so if you're one of those people that is having trouble with medicines, doesn't want to take medicines, you know, laparoscopic anti-reflux surgery is certainly an option. One of the things with that, some of the people that have surgery will require medicines after surgery. Typically, it requires less surgery. As with all of these, the people that do the best on all of those are the people that have milder reflux, and they do the best with surgery. They do the best with any of the procedures that get done. But they're also the people that aren't needing as much medicine. Their disorder is just not as severe. The people that really look for more relief are the people that are having more problems, and so because of that, they just have more difficulty to control with everything they do. Yes, ma'am.
Going back to the polyps that you mentioned, can they be, are they always removed, or is there a time when they cannot be removed?
They can be removed, and they can be removed with an endoscope typically.
I was under the impression that those were not removed, the ones
I guess I'll speak for myself. If I see polyps, I usually take them out, and I take them out really for two reasons. One, I want to get rid of them, but two, I really want to take them out so I can send them to the pathologist to tell me what type of polyp it is. You know, sometimes we'll see some tiny little polyps that may be a few millimeters, and somebody may choose not to remove those. If we see big polyps, we generally take them out. And the polyps, even though they may not be precancerous, just because of their size, they may have a little bit of potential for bleeding. They may have other issues. We don't worry about them turning into cancer. You know, usually you say polyp, and that's what everybody thinks about because that's what happens in the colon, or at least that's what we worry about. But they're a different type of polyp. So this is trying to show, and it doesn't come out very well, a fundoplication. A fundoplication is where it takes the stomach and actually wraps it around, and the surgeon will actually put sutures there to wrap that around, and so at the bottom of the esophagus here, it supports the lower esophageal sphincter to keep it tight. One of the things the surgeons can do is vary how tightly they wrap that. One of the things that we usually do before they have this surgery done is actually measure the pressure in the esophagus, both to measure lower esophageal sphincter, but really to measure the strength of the body of the esophagus. Because if the body is a little bit on the weak side, they want to wrap this a little bit more loosely. If the body has good strength there, they can wrap it a little bit more tightly and thus help prevent acid reflux. If they wrap it too tight, then they basically made it where you can't swallow, which helps your reflux but doesn't really help you otherwise. So this is well, that didn't come out very well either. So I couldn't get permission to show the video of these on any one of these. So this is a picture. This is a Strata procedure. And so we have a catheter, has a balloon that inflates, and it has a little needle that goes into the muscle layer of the esophagus. And you actually do a number of different radio frequency ablations in the bottom of the esophagus, the very top part of the stomach, to tighten that up. But that's you don't have to have an incision. It's a single procedure. It's an outpatient procedure. Strata, actually, we did some Strata procedures here. The company actually went out of business and has actually, another company has bought them, so that may be coming back as an alternative for some people. This is esophagus, where a device is put, again, through the mouth. The esophagus is pulled down, and they put little plastic bands, like the little plastic things that hold garment tag. So they put a number of those in the esophagus to make a high pressure zone. Again, this is still being done, but the utility of it is not as good long term, and I'm not sure that's going to really hold long term care. And then this is the Linx procedure. And again, I couldn't get a video. I really wanted to get a video of the magnets clicking together, but I couldn't get that. But basically, again, you have to go in with the surgeon, has to go in and take a ring of magnets, put it around the lower esophageal sphincter. It is allowed to stretch open so that when you swallow a bolus of food, it opens up, then clicks back closed. Yes, ma'am.
Does everybody with acid reflux have a hernia?
No.
No?
But if you have a hiatal hernia, your acid reflux is typically a little worse. So, yes, sir.
Is it Linx procedure, is that like an artificial LES?
Well, I guess I would say it supports your LES, yes. And it's the one that I've seen that is able to expand and close back. You know, all the other stuff I've seen basically are fixed supports, whether it was a ring, whether it's a fundoplication, all of those are relatively fixed. And so this is the one that we'll see how it goes. I think the initial studies short term look good.
Those are actually metal magnets?
Yes. Yeah, and I think that's one of the questions is, you've got a metal magnet sitting next to your tissue, is it going to eat a little hole there and cause damage? Short term, it hasn't looked like it's done that. Some of the other procedures, one of the problems with the angel chick, the donut that they put around there, that was one of the problems with it, is it actually would damage the bottom of the esophagus. It's going to eat a hole in the esophagus. As you can imagine, that's not a good thing.
If you're going to go through an airport security or something.
I'm not sure about that. I know you cannot have an MRI with that. I'm not sure if they're big enough to set the things off, or if they're big enough for you. You know, if you stand up in the scanner, can they see it and start to pull you aside and want to give you a body cavity search or whatever they're going to do? I don't know. I will have to say I just don't know that. So yes, ma'am. It can be repaired, and one of the things when they do a fundoplication, they typically will repair that. They'll pull the stomach back, down, and in the process of wrapping it around, it will repair the hiatal hernia. Now, sometimes we will see people with a small hiatal hernia we don't really worry too much about. It just makes you prone to reflux, and if we treat your acid reflux adequately, that's kind of what we do. Sometimes we'll see people that they have half their stomach up in their chest, and that's enough of the stomach there to just cause symptoms from that. And so sometimes we'll have people go to surgery to get their hiatal hernia repaired when they're not really having tremendous problems. We may be controlling their acid reflux, but just because of the physical size of the hiatal hernia, we think it is causing enough problems otherwise. So I guess in summary, gastroesophageal reflux is a chronic disorder, unfortunately. Does require some lifestyle changes. You do have a good opportunity with diet and lifestyle changes to really impact your life. Medical therapy is the standard, although there are some surgical procedures available to help with that. And I'm optimistic that there are going to be more procedures. If the magnets don't let you walk past your refrigerator, there's going to be other things available in the future for us to do. So, any other questions? Yes, ma'am. You certainly need to do that periodically. I think somewhere between that 3 to 5 years, one of the things we look at is, do you have dysplasia? Dysplasia is where the cells on the biopsy itself are trying to move toward cancer. Those people need a higher level of surveillance, meaning looking more often. I think it also depends on how much tissue you have involved. We can see some people that have a small little ring of tissue, not very much, or we can see people that have a fairly extensive amount of tissue of the esophagus involved. And my opinion is I think people with more tissue are at higher risk. I'm probably going to want to look a little more often.
I'd like to know what the difference is between, I don't know what they're called, but like Prilosec and GERD. What's the difference between them?
GERD, Prilosec, Esophagus, Prevacid, Nexium, all are in the same category of medicines. They're all proton pump inhibitors. As a separate category, Zantac, Tagamet, Pepcid, all are H2 blockers. H2 blockers meaning they block the histamine receptor. Histamine receptor is one of the things that stimulates acid production. We can control some people with Tagamet, Zantac, Pepcid category of medicines, but the PPIs as a group are a much more potent acid blocker and so do a much better job of that.
Well, why does Nexium require a prescription?
It hasn't been labeled by the FDA as going over the counter. I mean,
That's the only reason? Otherwise, it's the same as GERD and Prilosec?
it's the same category of medicine. It's subtly different. You know, when they first came out with Prilosec, Prilosec was the first that came on the market. It was also the first to go over the counter. The company, the drug company, is actually the one that makes the decision that they want to try and,
That's the only reason.
yeah, that's who decides that they want to take it over the counter. And same thing, Prilosec, omeprazole is the generic for Prilosec. Now omeprazole is available over the counter.
What about these liquid antacids? How effective are they?
They're effective short term, but they don't last very long. And so you could treat acid reflux adequately, but you'd probably have to take a liquid antacid 7 to 9 times per day. And your cost is probably going to be comparable, if not higher. And they have their own potential set of side effects. Most of them have magnesium, unless you have a calcium-containing one. Magnesium has the potential to give you some diarrhea or loose stools. The calcium-containing ones have a tendency to make you constipated, or you can actually take too much calcium and get some other issues. But if you want to take enough of them, they actually will suppress the acid. They don't really suppress it as much as they just neutralize it instantly.
As far as cause goes, at what age do people usually start having problems like GERD
It is something we will see in an older age group, but we are getting a better recognition for seeing it in kids. There's something called a happy spitter, babies that will just regurgitate without nausea, without anything else. They'll eat and just regurgitate, and they probably have a weak lower esophageal sphincter. Now, infants, the lower esophageal sphincter is not fully formed, not fully supported yet, and so they have an opportunity to get that strengthened, but some of those kids may not, and we've seen reflux in kids, we've seen it in teenagers, we've seen it in as a generalization, it is an older person's disorder.
So like heavy smoking or heavy drinking for a long period of time, 20 years, is heavy smoking and drinking
Contributes to your risk.
more so than food?
All of it together, I think. So, yes, sir.
What causes esophageal spasms?
Most common thing to cause that is uncontrolled acid reflux. You can have isolated esophageal spasm, and we don't always know what causes it. Most of it is caused by some type of inflammation, but you can have just isolated spasm of the esophagus. And so one of the things we would want to do is on that laundry list of stuff is go make sure that you don't have one of those other causes of inflammation. Yes, ma'am.
Wondering, my mom has advanced Parkinson's, and she's been on Nexium twice a day to help with it, and it works great. My question is, she eats spicy food, she's done the whole thing, and she's great. I don't eat any spicy food, and I'm getting acid reflux. Is any of it hereditary?
We don't have a gene marker to say you've got the reflux gene. We absolutely see families that everybody in the family has GERD, and as with most genetics, it's just bad luck.
I also found that is Nexium basically the top medication because she went through some of this other stuff, the Tagamet, the Zen, none of that worked. As soon as she got to the Nexium, it made a huge difference, but we weren't quite there. And then when he increased it to twice a day, we haven't had a problem since.
Fantastic. Good.
And it's
Good.
been 20 years.
Yeah, good for her. One of the things, statistically, if we look at all of the medicines in that category, they are pretty similar. There are some studies that show Nexium may be just a little bit better, but one of the things clinically we see is one medicine will work better on one person than another. If we take a study and do 1,000 people, they're pretty similar. If we take you, Nexium may be the thing that works the best, but I've seen Nexium not work on people and one of the other ones do, and there's no real good judge to say which one's going to work best, and so we just have to do trial and error and go through the process.
Well, and even with the way that you have the prior approval, I mean, we go through it every year. They would love to make her come back off of it. At her age, with her disease, I'm fighting them. No, I didn't. So I have to give them the names of the other drugs that she took.
Yeah.
It didn't work, and then they kind of back off. But it's every year.
Yeah, my advice is keep that list of the drugs that she didn't do well handy, because I think that's just going to get worse.
Okay, thank you.
Yes, ma'am.
I wanted to ask, I've been on Nexium for a little while, and then I worry about the side effects. Everything seems to have side effects, but those in particular worried me, so I went off of it, and I've done ranitidine, and then was thinking, should go back on Nexium. Can you on again, off again like that? What do you do when you do that?
You can do that, and one of the things, like I said, we will try and get people down off of medicines if we can. Some people we can, some people we just can't do that. If that's working for you, I think that's okay. One of the particular problems we worry about with the Tagamet, Zantac, Pepcid category of medicines is the effect of that will kind of go away after a while. It doesn't seem to really go away with the PPI category of medicines. And so if you're kind of alternating or whatever, and that seems to be really controlling things, I'm okay with that. I mean, that's how you're going to minimize the risk. The way to remove the risk of medicines is get off medicines completely. And for most people that I see, and of course I'm seeing the tip of the iceberg, you know, I'm seeing the people that are having more difficult problems, but the people that I see can't get off medicines. And so if they can't do the diet and lifestyle changes, or most of them have already done it by the time they see me, then we have to go physically do something to it. And it's either that choice of stay on the medicines or go have a procedure done.
Is there any relationship between like Barretts Esophagus and celiac disease, one to the other? Or
No.
are they completely different?
Different disorders. Okay, thank you very much. I'll turn you over to a wonderful dinner.